ready to go. Yes? Okay, we're ready to go. Well, hi everyone. It's great to have you here. Good afternoon. Launching the GW Alumni Weekend, launching all kinds of good stuff today. My name is Barbara Bass, and I have the great privilege of serving as the VP for Health Affairs and the Dean of the School of Medicine of the George Washington University School of Medicine and Health Sciences. And today we're launching another new kind of initiative here at GW as we begin our third century as a School of Medicine. And we are going to start a series that we are going to call our GW Med Talks series. And boy, do we have a great person to serve as our inaugural speaker during our bicentennial year. We have Dr. Jonathan Perlin here, who's with me up here. I said, stand here so people can see you right now. We'll get to see you even more, but he's not shy. And as you'll hear very shortly, he is just an exceptionally talented and internationally recognized leader in the healthcare industry. As you know, as I trust everyone here knows in this audience, but maybe not everybody, this is our bicentennial year at the GW School of Medicine and Health Sciences. That means we were founded in 1824. And you may think, well, I thought it was a couple of years ago. That was the university's bicentennial. It was 2 years ago. It took our school a couple of years later to get up and running. So we're 2 years after the founding of the Columbia College. And it's really exciting for us as we launch into our third century of training healthcare professionals. We've been at it for 200 years, generations and generations of talented, compassionate physicians. In our first 150 years and in more recent decades, like the last 50 or so, we've added all kinds of other healthcare professionals that we train and in our missions, including we have PA studies, we have physical therapy, occupational therapy, PhD in biological sciences. We have PhDs in health services research. We do a lot of our domain, our repertoire in research and in education is really exceptional and continues to grow over these last 50 years. We are therefore the 11th oldest medical school in the nation. It's pretty good. And we are the oldest here in Washington, D.C. With today's GW Med Talks with Dr. Perlin, this is the start of a whole new distinguished speaker series. And we will continue it going forward, as I said, for the next centennial. And this talk today, which he's going to give, couldn't be more timely. It's entitled, First, Do No Harm, Then Do Good, Equity, Environment, and AI. I know many in this room have known Dr. Perlin for a long time. I gotta say, I've known him probably for decades, and certainly known of him for longer than that. And he is really uniquely qualified to speak on these great challenges that are facing healthcare in our time. Today, he's going to address, by virtue of the title you just heard, three of the most pressing: equity, environment, and AI. I can't wait to hear what you're going to say about all this. Well, Dr. Perlin is a household name to us in the healthcare industry and in academic medicine. For those who are not familiar with him, by virtue of not maybe being part of that milieu, let me take a moment to introduce him to you. Dr. Perlin currently serves as the 7th President and CEO of the Joint Commission Enterprise, a role that he began in March of 2022. And for those that are in the business, you know that the Joint Commission is the leading national and international organization that establishes the standards for hospitals and healthcare delivery sites to maintain their accreditation as a place where you get your care. Let's just say this is a pretty important gig that he's got. Prior to his role at the Joint Commission, he served as the President, Clinical Operations and Chief Medical Officer for HCA Healthcare, where he led clinicians, data scientists, and researchers in developing a team to create that learning health system that led to improved care across its vast network of over 190 hospitals and about 22 other locations as well. His team's work achieved national recognition for preventing elective preterm deliveries, reducing maternal mortality, using artificial intelligence to improve sepsis survival, and developing public-private academic partnerships for improving infection prevention and treating COVID-19. Prior to his leadership at HCA, Dr. Perlin served as the Undersecretary for Health in the U.S. Department of Veterans Affairs, where I first encountered him as a leader, and where he led the Veterans Healthcare Administration to national prominence in a very visible way at a challenging time for full implementation of several important initiatives, including the first national electronic health record and the establishment of many opportunities to benchmark the healthcare that's been provided in that system to our veterans. He served on numerous federal commissions, including as a Congressional Budget Office Health Advisor, a member of MedPAC, that's the Medicare Payment Advisory Commission, that's the body that decides how much they're going to pay us when we take care of patients, and as chair of the VA Special Advisory Group. He's an elected member of the National Academy of Medicine, and he's co-chairs National Academy of Medicine Action Collaboratives on digital health, combating opioids, and climate change. He has received, needless to say, numerous awards, including the Distinguished Alumnus in Medicine Award at the Virginia Commonwealth University School of Medicine, and the Lifetime Achievement Award at that same institution. And he's even been recognized as the 10th honorary Green Beret and member of the Special Forces Association. Dr. Perlin received his MD and PhD degrees from the Virginia Commonwealth University School of Medicine. He had once aspired to become a clinician scientist in neuroscience, and somehow or the other was diverted to healthcare leadership and administration, but he could have done that too. He joined the faculty at VCU after training in internal medicine, and then as that was launching, all of a sudden found himself much more focused on healthcare performance and improving the opportunities to improve the care we provide to our patients. Today, he's currently recognized as one of the most influential leaders in healthcare, and he still maintains faculty appointments at Vanderbilt University, the home of the HCA headquarters, as clinical professor of medicine, and at VCU as an adjunct professor of health administration. I want to note that one of the reasons we're here today, having this lecture today, is because we had another very special event earlier today, and sitting here in the front row are the people that are part of that as well. But today, we are here with several great friends of GW. In the front row here, known to many of you well, is Dr. Seymour Perlin and his wife Ruth. Dr. Seymour Perlin, of course, is an emeritus professor of psychiatry and a longstanding member of our faculty in the Department of Psychiatry and Behavioral Health. We were here because we were installing Dr. Dan Carrero, who I hope is here. There he is, one of our new faculty members, as the Seymour and Ruth Perlin Professor of Psychiatry and Behavioral Health, a professorship that was made possible by a generous, incredible gift from Dr. John Perlin and his wife, Donna, who's here right in the front row. So we are so grateful to have you with us and celebrate that. It also reminds us that we have more than just 50 years of relationship here with the Perlin family. In fact, the Perlin family's relationship began 100 years ago when Ruth's father began his law studies at GW in 1921. 50 years later came Dr. Perlin the first, and subsequently we actually have in our class right now at the School of Medicine and Health Sciences a third-year medical student, Connor, who is the nephew of, the grandson of the Perlins right here in the front row, Seymour and Ruth. So we are really sort of celebrating all kinds of things today, but especially the Perlin family and the gifts that they have given us in so many different forms over the course of their long relationship with this university. So with that, I'd like to introduce our speaker. I'd like to have our speaker come forward. I've introduced him enough, but I want you to come here and speak with us and look forward to it.
Thank you very, very much. Well, good afternoon. Great to be here with you, Dean Bass. Thank you for that very generous introduction. It's clear you got the email from my mother. It's indeed a privilege to be here with family, as you heard, in an institution that our family cherishes. And it's a wonderful day to be here to celebrate Dr. Dan Carrero and his new role as the inaugural Perlin professor. And we wish you well in that role. We wish you well because this is an incredibly complex time, not only in healthcare, but obviously in the life of our country and in humanity. And given the opportunity to come to the Joint Commission, it's really a podium, both in the United States and abroad, to do good things. So I wanted to share with you a little bit about our agenda and share with you some things that I learned during my course there. And I also, just on a personal note that this is an extraordinary audience, not only because my parents are here, but many dear friends are in this audience. Dr. Jeff Ackman, we consider the fourth brother, and friends from my VA days, Dr. Barbara Dayton in particular, and just a delight to be here amongst so many cherished friends and colleagues. So, of course, we want to do good in healthcare, but the first rule is do no harm. And this is really a call to action in a number of areas. And to set the context, I mentioned the complexity of healthcare, and it's really quite remarkable that this institution has stood for 200 years. And it was chartered to address the shortage of health professionals right here in our nation's capital. Now, if we go back 200 years, there were a lot of things that were interesting going on in medicine. The stethoscope adopted its current form. It changed from just being a sort of cone to having the tubes that we recognize today. But it was also the era when quinine was isolated from cinchona bark and became the standard treatment for malaria for 100 years. Well, I note that because as we talk about sustainable healthcare and climate change, malaria is surfacing again, and we'll make a little ellipse back to that shortly. Like any academic speaker, I do want to share what the learning objectives are and to introduce you to our HELP agenda, help you identify sources of carbon waste in healthcare and strategies for reducing that waste, and ultimately describe healthcare's carbon footprint and the impact of climate change on patient safety, equity, and health itself. In terms of disclosures, Joint Commission is a not-for-profit, non-governmental organization whose mission is to advocate for health quality and safety through its programs. Well, Dean Bass was kind enough to introduce you to my family, and it's really quite remarkable. 1824, the medical school is founded. 1865, the School of Law is founded. My grandfather, Robert Rudolph, apparently went there at exactly the right time because it became accredited in 1923. So just by the wire. Now, you meet the rest of the family there. Connor on the right, he's going to kill me for this picture. But a third-year medical student doing things, the hard work that third-year medical students do. My two brothers, one, Steve, a Master of Health Administration, and Jeremy, a graduate of the School of Law. My mother really helping with the Luther Brady Gallery, coming together at the Textile Museum, and board member there, and of course my father in the middle. So, what I have to say is this, that if you like this talk, it's really in honor of this extended family that, and GW. If you don't like it, forgive me, I didn't have the benefit of a GW education. Okay, now, as to the complexity in healthcare, I come at it from an operations perspective, certainly for the last few years, and have to grapple with three simultaneous realities. That healthcare organizations are struggling. There are shortages of workforce in the wake of COVID. Finances are tough, and finding appropriate places for patient disposition is very difficult, especially in behavioral health. Being in an organization that inspects hospitals, we know that the regulatory burden is tough as well. We also know that healthcare workers are struggling. You know, honored at the beginning of the COVID epidemic, it changed to really extraordinary anger in many ways at healthcare workers, a false attribution of the epidemic to them, and workplace violence in healthcare, depending on the source you read, has increased between 200 and 700% from pre-COVID. And so the moral injury, the burnout, and the subsequent attrition is very real as well. But at the center of all of this is the patient. And the patient deserves the highest quality care, safety, a positive experience, access, equity, affordability. And in a sense, when you try to solve, you have to solve for all three simultaneously. Patients deserving the best care, the community having access to needed services, the broad spectrum of services, and healthcare workers having a safe and healthy working environment. And this idea of multi-solving really comes from the concept of systems engineering, complex adaptive systems. And the way into it, oddly enough, is not through engineering, but through values. And a values-based approach requires you to both multi-solve and think about what are the priorities. And so I think we're familiar with the triple aim of cost, quality, and experience of care, but we have to add to that. It's just absolute that we have to add to that. We have to add equity, and I'll share a story of why that's so important to me from what I observed. And I will tell you, there was a point where some people suggested adding to the triple aim that notion of caregiver well-being. And 20 years ago, I thought that was self-indulgent. Today, I say I was wrong. It's absolutely essential in terms of being able to meet the other needs. But finally, if our goal is to do no harm and to improve the health of communities and individuals, we have to focus on sustainability and the health of our planet. So a little bit of history. The Joint Commission. Why is it called the Joint Commission? Well, sorry to disappoint, nothing to do with joints. It has everything to do with being jointly founded by the American College of Surgeons, carrying on work they started in 1913, Ernest Codman, who founded the American College of Surgeons. When World War II occurred, all the physicians who used to run hospitals got drafted off to theater, and afterwards there was a deficit of physicians, and the American College of Surgeons said, assuring that the technology is in place for safe care is important. Will you help us? American College of Physicians, Medical Association, Dental Association, and Hospital Association. And our vision is that all people always experience the safest, highest quality, best value health care across all settings. You can't get paid in the United States if you're not accredited. Don't have to be accredited by the Joint Commission, but you need to be accredited. And programs get certified. Most of the certifications are voluntary. What Dean Bass mentioned is that we also are international and actually do work in 86 countries where it's really a badge of honor to be accredited in those areas. And now the National Quality Forum is part of our family of organizations, and they work on helping to develop the best consensus-based, evidence-based performance measures. So this is where we get to those three areas: equity, sustainability, and AI. This is our agenda. In short, the HELP agenda, an acronym for those items you see before you. Health equity is now part of the required set of standards. There's more voluntary opportunity in that area as well. And I'm going to go through these sequentially, so I won't dwell here. But the P is really about performance integration. For those of you who've actually been involved in surveys, want surveys to be less performative and more integrated with the day-to-day operations, so we're focusing on the things that are really most important. So I'm going to shake up the order a little bit because I'm going to dive deep into environmental sustainability, but I want to take you through each of these priorities sequentially. My favorite quote on health equity is one that stands the test of time. 65 years later, unfortunately, it's still all too correct that of all the forms of inequality, injustice in health is the most shocking and the most inhuman because it often results in physical death. Now, what's really interesting is that this quote is often misquoted. But a woman named, a scholar at Wellesley, Charlene Galarno, actually went back to the source literature. Turns out that King spoke 3 times on that day in 1966 to community leaders in the morning, at the Medical Committee for Human Rights in the midday, and then the afternoon in a press conference. And his words were captured in 4 African-American papers. They were exactly that. And Galarno has deconstructed this as a matter of context. Inhumane means cruel. Inhuman means beneath humanity. And in terms of the context of the sentence, he didn't say, it didn't end with inhumane. It ended with a statement because it often results in physical death. So it turns out, in addition to all of his other extraordinary gifts, King was a very insightful health services researcher. He, by the way, also didn't talk about healthcare, but health. And sadly, if you look at the statistics from the CDC, if you look at the age-adjusted mortality using the OMB nomenclature, blacks versus whites experience over twice the age-adjusted mortality rate, and American Indian, Alaskan Native even higher. And oh, by the way, disparity costs money. Today, we spend $1/3 of $1 trillion on the challenges of disparate healthcare, a number that will grow to a full $1 billion by 2040 if we don't do better in terms of assuring health equity. The reason, just to draw a finer point on that I was absolutely felt compelled to address this, is that Dean Bass mentioned that at HCA we worked on reducing maternal mortality. In fact, given the privilege of 237,000 deliveries a year in a swath across the lower United States, which was not only as diverse as the rest of the country, but more diverse, against a backdrop where women of color experience over 300% higher maternal mortality than white women, and Latina women experience 150% mortality. In 2018 and 2019, there were 0 deaths in women of color. In 2020, with the advent of COVID, that changed. 19 women showed up at death's door. 2 had COVID. 17 had fatal disease because of dislocation from healthcare during COVID. Cardiomyopathy, end-stage cancer, and apropos of the connection to psychiatry, behavioral health here today, the majority were suicidal overdoses, not salvageable. And so what was always unacceptable to my eye became intolerable, and given the opportunity to put that at the top of the agenda for the Joint Commission, it earned that place as the H in the health agenda. Well, the defining technology of our century is really AI. And we know on this theme of equity that the misuse of AI has resulted in not ameliorating, but exacerbating disparities because of biases in the training data. And so it's pretty clear we need some guardrails. On the one side, there have been some really egregious episodes of amplifying disparity. But on the other hand, this is the tool that I believe offers more than any other in terms of improving quality and safety. And we don't want over-regulation. In fact, well before I had any inkling of going to the Joint Commission and well before the National Quality Forum was part of it, we actually, my team, won what's called the Eisenberg Award for National Innovations in Safety for an AI algorithm that spotted sepsis. Sepsis mortality increases by 4 to 8% for every hour in which diagnosis is delayed. And it's really interesting because I couldn't have this algorithm, say to a clinician that your patient has sepsis, because that would have to be a regulated device. We used what we called the peanut butter and jelly approach. 2 slices of bread, peanut butter and jelly. Could this be a peanut butter and jelly sandwich? Could this be sepsis? On top of benchmark performance, the use of that algorithm saved 8,000 lives in its first 18 months of operation across 63,000 beds. I want those technologies to be present. And so when you think about the guardrails, we need to make sure that we have guardrails to prevent bad things, but also not really lead to an area where we have over-regulation that stifles development, because we really have huge opportunities to improve healthcare. In fact, a guy named Andy Arbach at the University of California, San Francisco published a paper in January of this year that showed that 23% of patients who die or deteriorate in hospital do so because of a missed diagnosis. Misdiagnosis, misdiagnosis, number one. And AI can really help in this regard. Now, data created for the care of patients is called primary data. When it's used for operations improvement, quality, safety, or developing an algorithm, we call that then secondary data. And what are patients' rights? Well, patients should have agency, but do you really want every millisecond of blood pressure in an ICU episode? No, you want agency of how your data are used. You want freedom from bias. You want privacy and controls on data use. And at the same time, you want tools that improve your healthcare and healthcare for all. And so the group Health Evolution put together a group of technology experts and privacy experts that came up with recommendations. And we turned those recommendations into standards: de-identification, data controls like security, limits on use, selling of data, verification of the algorithm, transparency to the patients, and a governance process. And the governance process is really important because for a good algorithm, you need 3 things. 1, you need the domain competence in the area, call it heart failure. You need to be able to develop a reliable algorithm, so you need the AI. But you also need the cultural competence to understand what the biases are and to understand if an algorithm is going awry in actual implementation. That's why the governance is so important. Now, for those of you who are directly in healthcare operations and have experienced surveys, you may have asked the question, where do standards come from? Well, most of them are in law and regulation. The CMS conditions of participation draw from OSHA. So anybody who's seen videos about water bottles, that's OSHA, just for the record, and from the National Fire Protection Act, and from CMS itself. The Joint Commission, over a period of years, had added what we called above and beyond standards, and truthfully, they got a little unwieldy. And so I know this is going to break hearts everywhere, but we retired 400 standards in the first 18 months of my tenure. Only one new one in. And though it's attributed to Einstein, it may have other sources, but remember the adage, not everything that counts is measured, and not everything that's measured counts. We wanted to put the emphasis on what counts. Only one new standard in. Yep, healthcare equity. And about being integrated rather than performative, we wanted to help the hospitals and healthcare organizations integrate the have-to-dos with the want-to-dos. And so you can see here that there are a series of criteria: designate a leader, address health-related social needs or social determinants. Look at your own data. Now, this is really important. The average is often not wonderful, even if it looks good. My favorite Lincoln quote is that the man with his hair on fire and feet in ice water is, on average, comfortable. Well, not true. And if you look below the surface and you stratify, segment by demographic, sometimes you see that there are cohorts who aren't getting the best care. And this is what we're asking health systems to do: create an action plan, address, keep stakeholders informed, rinse and repeat. And this is just out. You're the first audience to see this. But in the first quarter of this year, or actually March to May of this year, looking across 121 health systems that got surveyed during that period, these are the areas that they were addressing: readmissions, mental health, maternal care, cancer care, interpreters, experience of care, diabetes, food insecurity, access to transportation, housing, et cetera. So it feels really good to be able to amplify what many organizations may have already been doing, but perhaps for some others, what they hadn't yet started doing. Now, let's go deep in environmental sustainability. Question and a confession. How many of you spent your professional career studying the effects of healthcare on climate change? None. Me neither. That's my confession. But when I came to the Joint Commission, Victor Zal, the president of the National Academy of Medicine, pulled me from the opioid collaborative that Dean Bass mentioned. He said, I need your help over here on climate change. And once I learned certain things, it was a bell that was rung that can't be unrung. So I want to share with you what I learned. Did you know that if healthcare worldwide were a country, it would be the 5th most polluting country? And if the United States were a state in that country, we are the most polluting state, a quarter of the worldwide healthcare carbon footprint. And 9% of all carbon emissions in the United States are from healthcare. And I hope to convince you in the next few minutes this is not only a social and environmental justice issue, it's a health issue, a health equity issue, and a patient safety issue. Did you know that according to the T.S. Chan School of Public Health, that 81% of primary care clinics were closed for at least one day in the last 3 years because of an extreme weather event directly attributed to climate change, i.e. they weren't there when their communities needed them most? Well, here's one of the things I learned. I always heard that, we're in trouble if we're 1.5 degrees above, but I didn't know what the above what. Turns out it's above the average temperature at the beginning of the industrial age. And it's not 1.5 degrees Fahrenheit, it's centigrade. And oh, by the way, it's not 1.5 degrees from now. We've only got about 1/10 of a degree left till we hit that point. Now, obviously there's a relationship between carbon dioxide and temperature, and you can see it here. But the skeptics might say, gosh, 100 years, that's nothing in geologic time. So let's go back a little further. Let's look into the ice and carbon deposits and go back 1 million years. Why 350 parts per million in the atmosphere? Because every time the atmosphere hit that level of carbon dioxide, the Earth was able to recover. Sadly, today we're at 424 parts per million, and we've got a long way to go to get there by 2100. So you've heard that, okay, if we arrest warming at 1.5 degrees, then we're okay. What do we have to do that? Well, all the other scenarios fail. The only one that gets us to that level is the one in the green, where we cut carbon emissions by 50% by 2030 and down to net zero by 2050. What happens if that doesn't occur? Well, lots of bad things. At 2 degrees, if you look at these maps, and the top left and the bottom right are respectively New York and Miami. 15% of a million population in New York and 94% of 3 million in Miami are underwater at 2 degrees increase. And you can see this is a worldwide: London, Guangzhou, Buenos Aires, and Mumbai, among the many cities. If you look out in the Chesapeake Bay here, Tangier Island goes underwater. And it's already among one number of the fading islands in the Chesapeake. And now let's dive in a health audience into the health effects of climate change. And I like to think of this as a bit of an unvirtuous cycle in terms of the exacerbations. As there is warming, you get obviously more extreme weather, but you get rising sea levels as the polar ice caps melt. Now, 2 things happen there. They go from reflective white to a heat-absorbing gray, but they also release extraordinary amounts of entrapped carbon dioxide, which helps to raise the temperatures, and you have that. And if you look around the ring, you see all of these health effects, and it may not surprise you in a couple of ways that, 1, the most vulnerable are least able to compensate, i.e. they can't buy their way out of harm, and 2, that you might say, okay, well, it's pretty obvious that certain diseases would be exacerbated more than others. Respiratory, cardiovascular, that's true. So look at these statistics. There's a book that came out last year, Jeff Goodall, The Heat Will Kill You First. It's an incredibly easy read because he puts the narrative together with lots of data. But look at this, 250,000 worldwide deaths from firearms in 2022, twice that roughly from extreme heat. 2022, people living in extreme heat worldwide, 30 million. 2070, 2 billion. And the heat deaths in the US have increased 17% per year now for 7 years. This is an August report, and I'm going to show you some additional data right here. This year has been the hottest year on record. Well, look at this curve. This came out just this month in JAMA Network, which shows heat-related deaths in the United States, and you can see an inflection point over the last 7 or 8 years where it's become even higher. And so you might be curious, okay, it's warmer, what are the mechanisms of harm? Well, here they are. Heat islands in particular are challenging, where the built environment doesn't reflect heat, it absorbs heat, it doesn't provide respite. If you look at this graph, you can see the daytime temperature and the nighttime temperature. You can see in that built environment that the human activities concentrated in cities create hot days and hot nights. You might think a pond is cooling, but it retains heat at night. It's really the absence of green spaces. And so really need to think in terms of urban planning and in terms of heat health, climate health, about different built environment where green spaces are purposefully, intentionally part of that environment. And sadly, one of the best examples of how extreme this is, if you look on the bottom of this graph, this is the heat wave in Chicago in 1995, where you can see the average mortality in the orange line. You see the red line superimposed, and it's really clear there was a difference. And that difference resulted in 700 deaths above average, and it was not equally distributed. If you look at individuals who were over 65, you look at non-Hispanic blacks, the rates of death were much higher. This is one of the mechanisms both of heat-related death, harm, but also really begins to give you insight into the disparities in terms of harm and the vulnerability factors. And so if these look familiar as social determinants of adverse health outcomes, they are. Demographic, geographic, biological and health status, sociopolitical conditions, socioeconomic factors all lead to extreme vulnerability to the exposure pathways: weather events, heat stress, air quality, water quality, food security, and vectors, bugs that carry diseases. And we'll come to that. But you can just see how fragile the environments are. And here, of course, is Hurricane Ida, even more recently, not Katrina, down in New Orleans. But let's go back to 2 weeks ago. Here's Tampa General Hospital in the wake of Hurricane Helene. They erected these barriers fortunately. We're able to continue operations, but you can see the magnitude of the tidal surge during that storm. Now, everything I've shown you, heart disease, respiratory, et cetera, being exacerbated, say, okay, that makes sense physiologically. But this other stuff, is this the United States? Waterborne diseases, algae blooms, civil conflict, mental health issues, migration? Well, this is a picture of Florida from 2 years ago. This is the red tide, as it's colloquially known. And it's an outbreak of an algae that proliferates in warmer waters. And okay, it's noxious, it makes you cough, but it also results in massive fish kills. Well, these are really productive fisheries. If you're a fisherman with a $250,000 mortgage on your boat, what do? You migrate. And those fisheries actually moved from the Mississippi Delta there on the left and around Florida up north to the Carolinas. And oh, by the way, our beloved blue crab from the Chesapeake Bay is moving up to Boston Harbor, and Maine lobsters are now in Nova Scotia as this occurs. And you know, the jobs follow the opportunities and avoid the harms. Well, what you're looking at here is when the panels that set some of the climate change goals is this Intergovernmental Panel on Climate Change. They met in Panama because that area that is parched and arid was formerly verdant farmland with pastures, with cattle grazing and crops growing. And obviously, none of that is supportable today. In the United States, we live in an area, an environment that we've referred to, and some of us grown up even knowing as the breadbasket of the country, breadbasket to the world, but it's really the Goldilocks zone of not too hot, not too cold, not too wet, not too dry. But look at this. This is where it moves by 2070. And so the farmers in Canada, in what was tundra, will be growing crops that formerly were here as this climate becomes much more tropical. And I know that obviously a large part of the political debates of the day are about migration, but think about the impact here of global migration as the World Health Organization and others look at the migration pathways that you can now see as eminently plausible based on that picture of Panama. If you're a sustenance farmer, you can't sustain. You move further north if you're in the northern hemisphere or further south in the southern hemisphere. Now let's look at the vector-borne diseases. Malaria, I mentioned earlier, dengue, encephalitis, et cetera, chikungunya. When I was a medical student, which wasn't that long ago, I didn't study tropical diseases as hard as I should, and I couldn't even spell chikungunya. Well, wrong. Timothy Weingard wrote that, you know, we think of mosquitoes as just sort of noxious summer pests, but they're really the apex predator. Since the beginning of humanity, there have been about 104 billion people. Mosquito-borne diseases killed about 52 billion of those individuals. Today, if you drew a string around the globe at the latitude of the Canadian-US border, every area that can reliably report epidemiologic data has chikungunya as endemic. That's a change. And if you look at the pattern of mosquitoes, you can see in 1960, there's this sliver on the Gulf Coast and Florida, but by 2015, the mosquitoes that carry these diseases are distributed throughout the United States and up to the Great Lakes. And you can see there are a couple different species here. One species that carries chikungunya and dengue, or breakbone fever, and another that carries malaria. In fact, as I was researching for this talk, one of the major notable cases of the last year was in Fairfax County. It's not that malaria didn't occur somewhere between Florida and here, it's just that it probably wasn't recognized, clearly it's this far north. And if you look at dengue, you know, as the mosquitoes come up from the Gulf Coast, et cetera, and land here in Washington, D.C., it's not that there weren't any cases in South Carolina, it's that it wasn't recognized. And every state in the United States now should be prepared for dengue, which, as I mentioned, takes its name from what it really translates to break bone fever, because it feels like your bones are breaking from within. Good news is there's likely a vaccine in development and on the horizon. Bad news is that the current standard of care is supportive, and though most people recover, end stage could lead to full cardiovascular collapse. Okay. Health issue, environmental issue, social justice issue, health equity issue, patient safety issue. Where does the carbon in healthcare come from? Well, we talk about the greenhouse gases, scopes of greenhouse gases. And I like to simplify it down to the stuff we do, the stuff we burn to power our buildings and vehicles, and the water we consume, and the stuff we buy, use, and invest in. And you might say, if you look at the stack, that 7%, that's not very much. It turns out the stuff we use is really potent. Fluorinated anesthetic agents like isoflurane and desflurane are between 1,600 and 3,600 times more warming than carbon dioxide. Meter-dose inhalers still use fluorinated propellants that were outlawed for everything else. We can change that. We don't have to use those things. And we can use dry powdered inhalers instead, and breath-powered inhalers, or just simply pressured air inhalers, and there are organizations that are making that change. And in anesthesia, these anesthetic agents, in addition to nitrous oxide, can actually be avoided. But if you just turn down the flow rate so it doesn't blow off by the patient, you actually not only save the climate, you save money. Kaiser Permanente saved over $20 million in 1 year alone just by turning down the flow rate so it didn't blow by the patient. Nitrous oxide, it leaks from old buildings in the walls, so just use a local canister and you'll do much better with that. Organizations like Seattle's Children's Hospital eliminated all use of these agents entirely. And you think about the population that needs meter-dose inhalers, et cetera, as well as the fluorinated anesthetics. If they can do it, it's inspiring that everyone else can. National Health Service of Great Britain actually has a plan to eliminate, it's become net zero actually by 2040, and they've eliminated these, made great progress already, and will be net zero on meter-dose inhalers and fluorinated anesthetics even earlier. We're also incredibly energy intense in healthcare. 5% of commercial floor space and 10% of the energy consumption in healthcare, and hospitals are about 3/4 of that. So if you want to actually cut the carbon footprint, we need to do better in terms of health and keep people out of the most energy intensive environment, hospitals. So that's actually a good lesson for primary care. As I mentioned, keep patients healthy. But for reducing the energy, actually, there are some really low-tech fixes. Memorial Sloan Kettering has an older building in Manhattan. They put awnings on those windows and cut their summer energy use by in excess of 30%. But the usual maneuvers, insulation, different windows, LED lights, et cetera, are not only investments in the climate, but they also, in the longer term, reduce the operating cost of healthcare itself. Again, the National Health Service has made extraordinary progress in this regard and will be net zero by 2040. Scope 3, the stuff we use, 82% of that stack. Did you know that the average hospital patient, in the care of that patient, about 20 pounds of trash per patient per day, or about a ton for every 100 beds. Ton every day. 15% toxic, sharp, radioactive, infectious, or otherwise hazardous. But when you talk in those terms, it's not really personal. And when I first came to VA, as you heard, I testified and I had statistics, but I didn't have a really good story. And came back and said to the secretary, I guess Lenin was right. 1 death is a tragedy, 1 million deaths are a statistic. So John, you're absolutely right, but don't quote Lenin. So I'm going to move from the statistic to the individual. And I want to introduce you to my friend, a nurse, a performance artist, a climate activist, named Maria Quick. She's also shares publicly. She's a breast cancer patient. And she wanted to show the impact of one surgery, a reconstructive breast surgery. I don't know if we have the sound for this. You can crank it on there. But she went to the hospital for, as I mentioned, breast reconstruction. And she made an unusual request. She made the request that, that all of the trash from her hospitalization be given to her. Now, you may be pleased to know there's some constants in the universe, because the first thing the team did is we'll have to check with administration. Administration said we'll have to check with our lawyer. Went to the CEO, who said she wants the trash, she can have it. And with homage to Da Vinci's person in the square and the circle, look at this. One breast reconstruction, 45-foot diameter. My operation, our opportunity is what this translates to. Now, maybe the gloves can't be reprocessed, but the chair of my board is a prominent surgeon. The forceps that were disposed of 20 years ago, he still operates with successfully on mission trips in South America. There's no evidence that shows that launderable gowns are any less effective than those that are disposable, but those that are disposable contribute to that waste. So I'll just give you a second to let this sink in terms of the magnitude as you think about what's going on not only across the street at the hospital, University Hospital, but in operating rooms across the country and around the world. What can we do? Well, if you look at this top one at UCLA, over 10 years, they got rid of 300 tons of waste, saved over $1 million. In the Cleveland Clinic on the left, they saved $20,000 a year by having circularity, the reprocessing and reuse of products that would otherwise be disposed of. And even right across the river in Inova, they've saved money by going to launderable. Again, there are opportunities that are really low-tech, low-cost, and obviously improve the waste that we generate. And again, the National Health Service is really inspiring in terms of their plan to remove these sources of waste and get to net zero by 2040. Well, you know, in a health environment, we think about the foods we eat, and when we go to shop, all other things being equal, price and taste, we look at the food label and say, gosh, this has more salt or more saturated fat. Don't we need a food label for carbon products, for all products that we buy? Don't we need hospitals and healthcare organizations to be able to look by the line item or the market basket? And indeed, this isn't Logitech, but we're at a Logitech. Every product that Logitech makes, a Swiss company, has a carbon label, and it tells you how much carbon is in that product. And all of the things being equal, wouldn't it be nice to be able to shop for the lower carbon product? We need to force our healthcare organizations to shop more thoughtfully in this regard. And that's part of what we're doing through our work in the Joint Commission and Joint Commission International. In fact, internationally, we just partnered with Geneva Sustainability Center for a worldwide set of standards. We did something unusual and unprecedented. We put all of the standards into the public domain so that there would be one standard worldwide. I did a lot of work in IT, and there's the old joke, aren't standards wonderful? So many to choose from. Well, we obviously don't want to choose from standards. We need to drive to a universal standard. We actually signed the White House Health Sector Pledge, committing to a 50% reduction by 2030, net zero for 2050. You now know the reason. And there's an anesthesiologist at Yale, Jody Sherman, who's probably the senior scholar in the country in this area. And she was very critical, said, hey, you Joint Commission, your standards drive waste. And so we didn't fight with her. We invited her to chair a technical expert panel to review our standards. And she actually said, gee, you know, it actually doesn't say that. But let's change the tonality so we can be more responsible. We did that. We also generated proactive requirements to accelerate efforts. And I have to tell you, this was not entirely well received, especially initially. And one of the great things about Joint Commission is that we can tackle things that frankly can't be done in government. When you think about today's polarization around issues, think of the issues we're tackling. Health equity, environmental sustainability, AI as examples. Well, 2 years ago, we put those standards forward. And then we had the Canadian wildfires. Individuals like my daughter in New York City woke up to a red sun and cloudy orange gray skies. And in Maui, there were wildfires as well. And in California, there was 14 feet of snow leading to intense flooding. Last year, there were atmospheric rivers leading to massive landslides in Libya. For those following internationally, 30,000 deaths because of flooding. In Montpelier, Vermont, the Vermont Hospital Association was dislocated from their headquarters because they had 2 feet of mud in their offices. So things changed. And the fish kills in Florida, even in that part of the country. And now there's reception to that. There's also a perception amongst younger individuals, individuals like my daughter, whom I mentioned, who say, you know, gee, do I really want to have a kid in an environment that bodes the way it's going? Individuals between 18 and 34, the majority do not want to work for organizations that are not proactive in terms of committing to sustainability. And even more surprising, perhaps, is that you know, we're not often asked to add more standards. This is one of the areas where younger individuals and clinicians are asking us, Joint Commission, you got to put some standards in this area. And in fact, the Commonwealth Fund, also in January, put out this survey of clinicians that found that the majority, roughly 80% across the board, thought that they and their organizations needed to do more in the area of sustainability. So our standards have 4 parts: a strategic plan, that there are designated leaders, and an operational plan. Measure in 3 of these 6 areas: combustible fuel, purchased energy, anesthetic gas, fleet vehicle, waste disposal, meter-dose inhalers, convert it to metric tons of carbon dioxide, rinse and repeat. Make progress, continue. Well, why do this? Well, carbon accounting is actually kind of tough, so it's a way to get started in carbon accounting, but it's also a way to really communicate stewardship to your staff, to your colleagues, to your community, if you get involved in this area. There are, under the Inflation Reduction Act, incentives for becoming more green, and the Securities and Exchange Commission, it's only a matter of time before that's part of the requirements for public companies, and it's already an issue for companies seeking bonds on the European market. And of course, we did this in a virtual way to keep the carbon footprint low and the costs reasonable. But you can actually get cash payments from not-for-profit organizations if you take action in these areas. If you buy green energy, if you're rural, you can actually get paid to set up greener energy. And here's the great thing. My friend Don Berwick, always good for a quote, he said, the great thing about benchmarks is that they're not theoretical. Someone's doing it. And as a recovering English major, there's a difference between hope and optimism. Hope is a feeling that something good will happen. Optimism is that same feeling based on data. And so I'm optimistic that if we do these things, we can make progress. We can improve health and health equity and outcomes. As my friend Mike Abrams, the president of the Ohio Hospital Association says, how in a, quote, ruby red state is every hospital behind the IRA? Well, the channel of engagement is for the financial opportunity while also addressing the social, environmental, health, equity opportunities as well. Lots of resources on our website if you have your interest piqued in this area. But let me close with this. So why do this? Increasingly, even among skeptics, the evidence is inescapable. You saw the pictures of that. It's a matter of environmental and social justice, health, health equity, and patient safety. I hope I've convinced you of that. That in a field where we have workforce challenges, is essential to recruitment and retention. There's financial benefit, but it ties directly to mission. If we believe that our mission is not only the health care of the individual, but the health of the population and the health of our communities, it requires mitigating our environmental impact. Otherwise, it's simply inconsistent with our mission, and it violates the first principle of doing no harm. But for me, I've mentioned my daughter a couple of times as the proud parent of a newly married daughter who tells me that I really think about the world ahead and what I might bring a child into. I don't want them to wake up to, you know, a red sun and gray-orange skies. I want them to be able to enjoy the same golden sunshine and blue skies that so many of us enjoyed in our childhoods, and that's the why for me. It's our mission, and it's our responsibility to do no harm. Thank you very, very much for this extraordinary privilege of being here with you today. Thanks.
Thank you so much.
Thank you very much.
Dr. Perlin, that was fabulous and very thought-provoking. I think it sort of falls into the Eldridge Cleaver line of if you're not part of the solution, you're part of the problem. Well, we actually have time for some questions if anybody would like to offer them, but we all are part of the problem. Yes, I'm going to back in the white sweater back there.
Minoring in sustainability, and I was just wondering how your plan to use AI, like I do see the benefits in that in like early diagnosis and catching things, but how that kind of fits into your sustainability plan given the immense energy and water usage that AI is found to have.
Yeah, this is a great question, and thanks for taking interest in sustainability and a really exciting major for the future. But AI is a problem. It's the information intensiveness of our society is leading to server farms the size of the Superdome coming online every 3 days with huge energy consumption. So the bet is this. One, that we have to do better, that AI can help us to be more efficient in the delivery of our operations so we use less resource, it can better help us manage the energy consumption, it can better help us with diagnosis, et cetera, so that we can actually bend that curve there. But there's also, this is kind of an interesting story, some really far out ideas. And so my wife and I had, Donna and I had the privilege of hearing Jeff Bezos speak, and you might wonder, where the heck is he going with Jeff Bezos? Well, it turns out that Jeff Bezos was a physicist at Princeton before he actually took the trajectory he took. Turns out that while his roommate was doing differential equations in his head, he couldn't do it on paper, but it seems to have worked out. Why is he interested in Blue Origin and putting things into space? Turns out he's extremely interested in just your question, which is this, is that we don't want to forego the benefits of energy or an information-intensive society. But his notion is that you could actually put the processing in space, harvest silica there, and beam the information back to Earth, so you don't have to not only generate heat computing, but generate heat also cooling the equipment that computes. So it's really an extraordinary idea, and it'll take individuals like you coming up with really novel ideas. Turns out the other is that if you launch a rocket, a large rocket, just into space, enough to escape gravity for a moment, let the Earth turn and bring it back, it actually has a lower carbon footprint than a super freighter going across the Pacific. So there are some really extraordinary ideas, and I realize it's a little field of how it impacts healthcare, but the opportunity space for AI to be defining in terms of improving quality operations, et cetera, and help us save resources is one. And the second opportunity space is really things that at one level seem like science fiction, but when you think about it, AI was science fiction 25 to 50 years ago. So great question, thank you.
Okay, here with Christina.
So I wanted to share for people in the room who don't know, or if you don't know, that last year at GW, we started the first climate and health equity theme in our School of Medicine and Health Sciences, and that was student-led, student-driven, and supported broadly across the faculty. So just speaking to what you're saying, that our youngest adults are driving this movement, and we are responding to them here. I really appreciate the standards moving forward to help drive healthcare leadership to invest in the necessary changes to really make this happen at the level it needs to happen. But for each of us who is seeing patients day after day, what are one or two things that we can do to change our own practice? Because I still have to put on the yellow gown, and I still have to put on the gloves. And how do I order the albuterol that's not an MDI that I have in my home for all my asthmatic kids who we see the changes with our summer seasons?
Yeah, great set of questions, and thank you for what you're doing. I think this connection to health equity is why HHS did not start the Office of Climate Change, but the organization is called OCHI, Office of Climate Change and Health Equity. Yeah, there are things that you can do individually. You can join with other faculty in looking for alternatives to the traditional meter dose inhaler, and try to get the purchasing to focus more on some of the breath powered for kids who can do that, and compressed air or alternatives. In terms of gowns and gloves, et cetera, we should have a really science-based discussion about when you need to gown up and change, because if you look at that literature, it's actually not what we think it is. And it was interesting, during COVID, we became a whole lot more vigilant about using gowns, gloves, and masks when we didn't before. We haven't yet sort of left some of that behind. And in fact, if I forget all this stuff, if I could only do one thing to improve patient safety overall, it would be better hand hygiene. And that's an area where it's not about the gloves; it's about our own behaviors. So there are a couple things that I hope are practical for you. But with your faculty, exert pressure on the purchasing of products to help to educate patients about those things as well. Thanks.
Okay, let's take these two and then that'll be all we're going to have time for.
Really great presentation, thank you. Disclosures, proud GW alumnus, and milk in school now, so I'm intruding on med. Fantastic event. Questions, I just met someone at Quigley's who said, there's all this talk about the medical industrial complex, Mark, but they're jobs, right? Like, any other sector, the economy grows and we celebrate, but healthcare, we say, whoa, wait a second. And maybe related is your sort of journey. You were on these topics ahead of time. What has that been like personally from, in that environment of healthcare in the U.S. where spending's supposed to be great and you're carrying this message? Could you share a little bit about that?
Yeah, well thank you for that question. And, it's a great segue back to Dean Bass's opening comments about the professorship. If I've been at this sort of cutting edge of some of these topics, it's because I've always been grounded in a university environment. And I mentioned this earlier, is that universities are tremendously important to the function of democracy. They underpin a civil society. They underpin informed decision-making. And I think if I've had any particular advantage in this area, it's really having one foot in industry, if you will, and one foot in academia, because this is where the knowledge is being built. Thanks.
Thank you. One last question, huh?
Thank you. My last question was, because AI is pattern-based, could you see it being restricted to specific fields such as forensics?
Oh, that's a great question. So I want to suggest that there's an article you might want to read, and it's by Michael Howell and Karen DeSalvo. It's called The Three Epochs, not epic, Three Epochs, E-P-O-C-H, of AI. So early AI has actually been around for a bit. It's kind of the if-then rules. It's Bayesian mathematics, and if your patient has a blood pressure here, you want to treat with that. So you don't want to overregulate that. That can apply to a very specific use case. And then there's the next epoch of AI, which is deep learning and machine learning. And this is like computers that are trained to read mammograms. And already, computers can be trained on literally hundreds of millions of mammograms. I hate to tell you this, those readings are more reliable, way more reliable than low-volume radiologists in mammography. Now, the radiologists have an advantage in the weird presentations, but this is an area in terms of the pattern recognition where you need to develop a technology and it's certified for one use case, train on mammogram reading, apply to reading mammograms. Okay, that's epoch 2. Epoch 3 is the one that's really challenging, interesting, exciting, frightening, and that's deep learning. Generative AI, sometimes called foundation models or large language models. And what's interesting here is that the use case that is not specific. It was trained broadly on general knowledge, so like ChatGPT or Gemini, et cetera. And then you apply it to a general use case or a use case that hasn't been anticipated. So like taking USMLE, step 1, as an example. Sometimes it does really well. And sometimes there are unexpected results. And that's the area we probably want a little bit tighter regulation on how that's used. But you wouldn't want it to sort of constrain the if-then or the really successful deep learning models, but you really want to focus on how the generative large language or foundation models are used. And that's both the area that's incredibly exciting in terms of the opportunities, doing things that we never anticipated, and hate to say it, it's also the area that's really scary, doing things that we never anticipated. Thanks.
Well, I want to thank you for this on behalf of this group. I want to thank you for this fabulous talk. I also want to say that I personally feel reassured knowing that we have visionary leaders out there who are in a position to have real influence that can really help us make these badly needed changes. So thank you for stepping into one more challenge, as you always have done.
Thank you, Dean Bass.
And now we do have a reception upstairs for those who would like to go up and have a little something to drink and something to eat. It's up there, and we'd love to have you come and mingle with us. So thank you very much for being here, and again, thank you, Dr. Perlin.